Will you introduce this case?
Yeah, sure. Yeah. Good morning. Good morning, everybody. Yeah, I am Hyeon-Cheol Gwon from Samsung Medical Center. This is a very famous Indonesian doctor, biggest shot in Indonesia, Dr. Teguh Santoso. He's an expert of BVS and bifurcation, a lot of new devices. And the third operator is Dr. Jang Woo-Jin Chang from Samsung Changwon Hospital. He worked together several years ago. So, Dr. Jang, will you introduce the first case?
Okay. I'm Dr. Jang from Samsung Changwon Hospital. Let me introduce our case. This patient is a 54-year-old male. He was referred to outpatient clinic of Samsung Medical Center because of detected coronary calcium in routine chest CT. He had a mild external chest pain on history taking. His past medical history is only diabetes. Baseline echocardiogram is normal. Next, please. Exercise test echocardiogram was done previously at outpatient clinic. Stress echocardiogram showed akinesia on the apex to mid-septum wall of LV after exercise. Treadmill exercise test showed horizontal depression on lead 2, 3, V5, V6 from stage 3. Next slide. This is a baseline coronary angiogram. There is no significant stenotic lesion on right coronary artery. However, on left coronary angiogram, there is a diffuse non-calcified stenotic lesion on mid LAD. Next slide. Next slide. There is another stenotic lesion on bifurcation region. I think this is a true bifurcation region, maybe not 111. The angle is acute, relatively narrow. Next. Dr. Gwon previously performed the PCI for mid-LAD region using BBS, observed 2.5 times 28 millimeters. Next. Dr. Gwon.
Yeah, so let me show you the angiogram today, and Dr. Santoso will explain about the plan. Angiogram, please. Yeah, this is today's angiogram. Actually, left main ostium is diseased and calcified, so I was careful not to dissect the left main ostium at this angle. This is very scary. The next, you can see the bifurcation lesion, LAD os and left main circumflex. This calcium is mostly on the top of the left main lesion. Next. So you can see the mid LAD, and you can see some spots there. There's a absorber was implanted, a little bit short, but I think the result is okay now. Next. So we did IVUS. IVUS on the screen, please. IVUS?
We cannot see IVUS. Okay.
Yeah, IVUS on the screen, please. Okay, this is from mid LED. 너무 빠른데? 더 밑에. Yeah, from the. Actually, most important finding in IVUS for bifurcation stenting is the vessel size. Also, the classification distribution is important. So, from mid LED, we can see the vessel size is about 4, the lumen size 3.0. So basically, we need a large stent. It's proximal to septal diagonal branch. LED is 4.0, definitely 4.0 vessel. This is very large. There is about 30% diameter stenosis here, not severely calcified. And where is the main? Yeah, circumflex is coming from the 8 o'clock. Yeah, there is 50% diameter stenosis, LED ostium, and severely diseased in LED distal. So
No.
no, calcium is coming at the top of the about 12 o'clock, the 11 to 4 o'clock. Calcification is a little bit deep and less than 180 degrees. So osteum is also disease and the vessel size is 6.0. So Dr. Santoso, will you, maybe we can discuss?
Okay.
Yeah.
Okay. First of all, I would like to thank Dr. Kwon and all the
Thank you very
organizing
much.
committee for giving me the honor to take part in this prestigious, very prestigious meeting. As you may have seen the angio and the ALPS findings, this is a true bifurcation stenosis Medina 111, where the LED diameter is at least 4.0 and the left main is very big, normal, and 5 or more. And this disease process extends up to the ostium of the left main. So definitely we cannot use the BVS for left main because of size limitations. For BVS, the maximum size that we can use is 4.2. So this is too big. And for these patients, Dr. Gwon has decided to use, right from the beginning, two-stand approach. So one stand extending from the proximal LED up to cover the ostium, and the other one is BVS across the DES to the circ. So, of course, you may argue that this is a very simple bifurcation. Of course, this is a true bifurcation stenosis, but the disease extends is less than 5 millimeter from the circ ostium. There is currently several ongoing studies, among others the EBC left main, just to know whether in this kind of situation, two-stent strategy is better than one-stent strategy or provisional stenting strategy. In this particular case, we decided to use one stent to implant one stent across the circ ostium and BVS to the across the circ ostium from the left main ostium to the LED, and then BVS to cover the circ. And of course, for this, we know that BVS has a large profile. The profile is 1.4, so we need to do pre-dilatation. And of course, very important also is to reintroduce the wire into the circ in the distal stent, not in the proximal stent, in the distal stent, in order to be able to cover the ostium. So the two-stent technique that we will be using is the TAP technique. So after this, of course, we will do a kissing balloon dilatation to optimize the result, and we'll check this with the OCT. You may also argue why not IFOS, because we have used IFOS. We love to use OCT because with OCT we can get very detailed information. For example, even wire position, we can get some idea about this from OCT. But also, if we have malposition or disruption or fracture, or even mini fracture or mini thrombus, we can detect from OCT. So OCT is very helpful to study the result, to assess the result of our case. So we will begin with Dr. Kwon.
Actually, almost reviewed our plan. So this is a young male patient. So I first, my plan was implant 2 PVSs for left main, but left main is too large. So DES for left main, and if we implant the PVS for circumflex after 2 to 3 years, he's end up with just one stent technique left in his artery. So it'll be very safe for him to live 40 years, live more than 40 years. Next slide.
Dr. Kwon,
It's very wise.
this is Moon Hong.
Yeah.
I have a question whether the
Yeah, nice to
BVS
see you.
at osteal location, especially when you may have to crush the proximal portion,
Yeah.
whether it really does provide advantage for this bifurcation lesion. I know the rationale for the strategy, but I'm just wondering, practically speaking,
Yeah.
if there are more cons than pros in selecting BBS for the osteal surgery.
Right. There is two arguments against the TAP technique for this circumflex ostium. First thing is, as you mentioned, that there is a risk of fracture when during the kissing ballooning. Usually, recommendation is a mini kissing ballooning for the purpose. The second is that the osteal location. There is a lot of risk of a scaffold fracture in the long-term follow-up. So actually, I don't buy that too much, but some people is worrying about that. So we don't know. But I think that I have not seen many stent fractures, DES in the circumflex ostium before. So based on my experience, I'm feeling free to use the BBS for circumflex. Next slide. So for TAP technique, recently the BBK2 trial showed that the QLOD is much better than TAP. I think TAP is very kind of poorly done in that study. Maybe there's a possibility. So location of a stent is very important. Too much protrusion, there is risk of stent thrombosis. Too less, you will miss the ostium or circumflex. So the margin of stent, understanding the proximal margin of stent is very important, especially in BVS. In right side panel, you can see the BVS end is at the middle of the balloon marker, not in the scaffold marker. So this is quite challenging to get the very exact location of circumflex ostial.
Do you see the slides? This is very important slides. You see the slides of Dr. Gwon?
Yeah, sure.
Oh, okay.
Yeah.
Okay.
They're seeing.
Yeah.
We can see.
Okay, so what other issues you like to raise from the panels? I'd like to ready to hear.
I think the only
So we can use stent boost to get better visualization of the markers. Stent boost or stent fist.
You don't have a stent boost.
Oh, yeah. Sorry.
Sorry. Okay, otherwise the angiography, angiography on the screen. Okay, next. We did IVUS, and we pre-dilated with a 3.5 20 millimeter balloon with the pressure 14, next, 18, because there is a lot of calcium in the plaque burden in the left main, next. So we try to find the ostium of the left main because coverage of left main is very important. So I tried shallow LAO view, but Dr. Santoso suggests next. Yeah, this is just a LAO view. It's very, very good to see the just ostium of left main. We are convinced about that. Next. So we dilated the circumflex is 14 atmosphere. Not to touch too deep into the circumflex. Next. It looks large when you look at the angiography. Balloon is large, but based on IVUS, you can see a very good preparation for the circumflex. So it is really well dilated, and I think the BVS is working good for this after this very good preparation. This is what we have done so far. So we like to implant a stent from LAD. So
Okay.
we
Any comment from
selected
the
the
panel?
Science Alpine.
Okay, go ahead.
Yeah. Science Alpine 4.0, 18 millimeter.
Yes, sorry.
Okay. Yeah. So we measured the length from the LAD and about 15 millimeters. So ostium is the most important. Find ostium most important part. LA view. So Dr. Santoso helped me a lot.
I learned a lot from Dr. Gwon.
Test.
He's my teacher.
Test.
Test.
Okay. Best position is the halfway above the lower portion. and the inside of a higher portion. Test.
테스트.
No, it's moving according to respiration. So I control the respiration for the purpose. Another point is that too high pressure, it will compromise the circumflex. So nominal pressure is 10. I start with 8 atmosphere. This is what I mean. Okay? 환자분, 숨 쭉 들이쉬시고요. 반 내쉬시고, 예, 숨 참으세요. I hold the breath. Test. Okay, inflate. 8, complete.
8.
Yeah, 숨 쉬세요. Yeah, just 8 atmosphere. Okay, deflate.
8 is below nominal. Nominal
Below
is
nominal.
11.
Yeah, 10 actually.
10.
맞아. 10 actually. Yeah, spider view. I will look at the circumflex ostium at this moment. 엔지오 준비.
네.
Shoot. So, what do you think? We need to rewire at this moment?
Yeah.
Okay. So a little bit compromised, not too dangerous, but I like to remove the balloon and together. It's quite easy, quite safe to remove the wire from circumflex. And I need actually a guiding catheter aligned with the stent. So I push the guiding inside a little bit. So maybe you like to push the balloon inside, right?
Yes, it's
Okay,
very good
so
technique.
Actually, it is not going well.
Yes, to avoid damage of the proximal end of
Yeah.
the stent.
Right. Usually I pull it out,
Yeah.
pull back the balloon, but Dr. Santoso recommended me. This is a prolapse technique. Yeah. As you see, this is to avoid the wire undermining. Test.
테스트.
Actually, wiring was kind of difficult. Or you can do a part technique for facilities. But it's kind of difficult. I do the part for this purpose. Okay, test.
Okay,
Oh,
this
yeah.
is very good.
Yeah.
So, if we can introduce the
Okay.
wire to the distal struts, it would be better.
But sometimes
Because
it's no
sometimes
choice.
if it's too narrow, we
Yeah,
cannot,
no
cannot
choice. Yeah.
differentiate.
Yeah. So anyway, we put the stent, like to put the stent, the circumflex. So I dilate more over left main, inflate, and then left. Oh, no, not yet. No. Okay, inflate. Yeah. 14.
14.
Yeah,
This is 14.
14.
Go higher.
Maybe too deep. Different. Deflate. And pull. I like to pull it out. And okay.
Another.
No, not yet. We remove the guiding. Okay, inflate. 18. Yeah.
This is
just,
18.
Yeah, mini
18.
part.
Okay,
Deflate.
deflate.
Okay, let's see the EBS guideline actually prefers the part before side branch wiring. Yeah.
You usually do the part after side branch wiring, Dr. Gwon?
Yeah, because sometimes the part we miss the location, exact location of the balloon. It'll compromise the circumflex ostium. This is disastrous. So, if I try to rewire before part, it fails. I do the part. So it's a modification of the guideline actually. So angel,
네.
shoot. Okay, it's a compromise still there.
Compromise, but should be okay.
Should be okay. So I like to introduce the circumflex balloon. The 3.5 줘봐요. 3.5.
So if we want to apply the two-stent strategy right from the beginning using BBS and DDS, another option would be, especially if the angle of separation is considered to be challenging, we can use the T technique. So instead of implanting the stent the first stent in the left main LED, we implant the stent in the first stent in the circ, and then do kissing balloon dilatation. This is very important. Kissing balloon dilatation before we introduce the second stent from the left main to the LED, and then deploy the stent, and then not necessarily, but sometimes we still need another kissing balloon dilatation, but both is very important.
Yeah.
So with this technique, this is easier, number one. Number two, we can avoid having too much of struts, BRS struts protruding into the left main.
Sometimes a 3.5 pre-dilatation balloon cannot cross the circumflex, but
Yeah.
if I put the balloon in the LED, it's kind of a little bit anchor
Yeah.
for the circumflex. So I was successful
Correct.
for this case.
Yes, yes.
Very happy. Ready to pre-dilate. So this is circumflex, right? I like the circumflex balloon first. Yeah.
Yeah.
10. Okay. Okay, deflate. And kissing ballooning, right? So, yeah, together, 8.
8.
8.
This is kissing.
Yeah, 10.
10.
Left main is huge, so 10.
10 already.
Okay. Okay, deflate. Okay, great. So actually, I need anyway the 5.0 balloon, short balloon for a part technique for left main anyway. So, but for part, I have to remove all the balloons. But for this technique, very simple, very easy to proceed. Okay. And angiogram first. Maybe you can do part before stenting. Okay? Angiogram.
네.
Sure. Yeah. Maybe there is some argue that we have to stent the circumflex or not. But anyway, we found in IVUS, I didn't show the IVUS for circumflex. So anyway, this is disease, the length is about 5 millimeter. So,
Dr. Gwon,
and BVS, I
I'm-
believe in BVS. Yep.
Doc-
Usually in the 2.5 vessel, I use a DEB. This is just anecdotal case report has been published, but DEB may be better than just a balloon for side branch. But I don't think it's better than DS. What do you think?
Yeah. Completely agree. What is also interesting with DEB is that not only that we don't add additional metal or foreign materials,
DEB
but also if there is some dissection on follow-up, we see that dissection disappears. The dissection doesn't persist for a long time. It will disappear by time. Of course, this is another option.
So maybe you have 5 minutes. So our plan was to implant the BVS after 15 minutes, actually. So yeah, I tried BVS implantation.
No, because I do believe the skill of Dr. Gwon. He will manage everything. It's number one. And number two, we have done proper pre-dilatation. BVS has a big profile, 1.4. And we have used, I think, 3.0 balloon or 3.5 balloon to help create the 3.5 balloon for circ pre-dilatation.
Actually, he's right. I think even 7 French.
Yes.
I tried that. The balloon catheter inside, and the BVS cannot go in.
Yeah.
But because BVS is too bulky, so
Yes.
in that case, usually I insert BVS first, then insert the balloon.
Yeah.
So, but the balloon here is the 4.0 stent balloon. So it's kind of difficult. Yeah, I agree with you. So
4.0.
part. So I like to do the part, the proximal optimization first. The 5.0 balloon proximal optimization first. After T-stenting, it's kind of difficult to make the sufficient adequate part for the risk of damaging the circumflex BVS. So I like to do the part first.
This is a very good strategy because after pot, you'll get a better opening of the cells.
Okay.
And I completely agree with Dr. Kwon because BVS is bulky. Sometimes you can encounter resistance while you advance your BVS across the stress. Not
Okay,
only the starch, but if you use iron
12.
or OCT, sometimes
12. Okay.
you may also not be able to advance your imaging
Okay,
devices
deflate.
across the BVS.
Deflate. And inflate 18.
This is 18.
Okay. Okay. Test.
테스트.
준비. 엔조.
네.
Sure. Yeah. Okay. And ready to implant the BVS. So as I just said, that I insert the BVS first, not the balloon first. Usually, I tried that, but the BVS they cannot cross even 7 French.
Yeah.
7 French to cross the another balloon in the LED.
So 7 French guider can accommodate 1 balloon and 1 BVS, but not 2 BVS.
Yeah, not. Yeah. Okay. This is 3.5, 12 millimeter BVS. Actually, this is GT1. Oh, I'm losing wire here. Okay, GT1 and the pushability of a BVS is improved. This is basically, shaft is the Zion's Alpine design. The previously Zion's V design. This design is balloon is much pushable, and hopefully it can cross the circumflex very easily. How about that? Oh, it's not that easy. Let's align the guiding catheter. And I'd like to finish the session here. Okay? Give me 5 minutes more.
Okay.
Test.
테스트.
Okay, I'd like to join angiogram.
네.
Shoot.
Maybe
How about that?
need more proximal.
Need no proximal. The middle of actually this is okay. The balloon marker, center marker is the edge of, but for the safety a little
we
bit
don't
more.
cover the
The
osteo.
carina,
We haven't covered yet the carina.
yeah, test it.
테스트.
We need to.
Yeah, I think it's okay. 준비, angio.
I would
Too
prefer
low?
to-
Too
I would-
deep?
Yeah, too low. I would prefer to.
Okay,
Looks too
okay,
distant.
1 millimeter more.
Slightly
Test.
more.
Test.
Too distal, yes,
Test.
correct.
This
You have
is
to look
okay?
at the
Angio?
marker,
Okay.
platinum
Angio?
marker.
네.
Just looking at the balloon marker, not the platinum marker. Balloon marker
Yeah,
is
balloon
the edge
marker
of the
is at
stent.
the end of the
Okay.
stent. Yes,
Start
it's
here.
kept- okay.
Yeah.
Okay.
2. Yeah. 2.
Yes, we have to
4.
advance it
Yeah.
slowly.
Slowly, just slowly.
Yes,
Not
yes.
too atmosphere at 5 minutes. Yeah. 6.
8,
Okay. 10.
10.
Yeah. I'm looking at the vessel size. I stop here. The maintaining 30 seconds. Is this the usual practice? Is that right?
Yes, yes.
Yeah.
At least 30-second
Yeah,
inflated.
faster than the recommendation, and keep the duration, right? So I'm looking at the 10 seconds more. Okay, deflate. And usually the restenosis occurs at the ostium of circumflex, mostly because of underexpansion. So I'll pull it out a little bit. Oh, but
Yeah.
I forgot to introduce left main balloon here. Yeah, I'm sorry, but usual practice is put the balloon in LED and
Oh,
do the circumflex balloon. So
Okay, inflate.
Sorry about that. Yeah, inflate 18.
You can go fast until
18.
Until 10.
This
then
live
slowly.
demonstration. So distracted.
Okay. This is
Yeah, to
16.
maintain a little bit more. Even post lactation, I like to maintain a little bit more.
16 is slightly above the
Yeah, deflate.
rated.
Okay, so actually, we need to get the balloon in LED. So I'm not sure the balloon will cross to LED at
It
this
will.
moment. Okay.
네.
Yeah,
Okay, good.
that's okay. So LED stand balloon.
4.0 아까
So I put down the DS balloon here.
Yes, perfect. This,
So I tried the balloon to actually the BBS balloon in the circumflex. I tried to push the Zion's Alpine balloon in the LED, but there was some wire cross, so I removed it. So that's why wire is on the diagonal at this time. So, but it was not difficult to cross the standard balloon into the LED, cross the BVS on the circumflex. Next, and the BVS balloon too. Okay, next. With the kissing ballooning, with the 12 atmosphere. Next. This is the angiographic result. So there is some suspicious underexpansion in the circumflex, but actually it was by the overlap. Next. The epicaudal is well expanded, and the OCT on the screen, please. Circumflex. Can you put the OCT on the screen? Okay. Dr. Santoso, will you explain about the OCT finding?
Okay.
Yeah, you can see it that way.
So this is can
complex.
you move slowly? Okay. Yeah. Okay. This is distal to the scaffold. Now we move. This is stop. Yeah. So we don't induce any distal dissection. So the choose of size, the BVS size is correct. Can we go back more distally?
Distal.
Frame by frame. A little bit of this dissection, but not much. This is
Really?
acceptable. Move frame by frame. See,
Okay.
at in between 2 to 3 o'clock.
Okay.
But this is acceptable. Okay.
acceptable.
Can we go upstream? So the BVS is well expanded and well opposed. Okay. Faster.
좀 더 빨리. 빨리.
Well opposed, and the vessel looks quite concentric. Go faster. There are some calcifications here.
Yeah,
And
here.
now here we have the bifurcation. You may appreciate at the longitudinal view that the ostium, circ ostium is already wide, frame by frame, and the scaffold is well opposed to the vessel wall, covering the whole ostium, which is nice. And of course, at the junction between the circ and the left main, you see some struts hanging, and this is quite normal for this kind of procedure.
Tegu, how do you tell whether the
go ahead.
two strokes, the 2 and 3 o'clock, the strokes, are they disrupted architecturally, or how do we tell whether
Yes,
yeah.
we always see something like this if we do T-stenting, but as long as the amount of struts protruding to the main vessel is not much, usually it doesn't matter. And the second thing is that because of the left main and the side branches are big vessels, it also doesn't matter. Can we go a little bit downstream? You see here, there is some malposition, but this is also acceptable.
Yeah, a little bit small fracture due to kissing ballooning. This
Yes,
happens
yes.
by the kissing ballooning from the tap technique. It's quite stable, I think.
Yes.
How about the stroke with the
shall we
4
go
o'clock
to the
position?
LED?
The
LED.
stroke,
Four
Dr.
o'clock,
Kwon?
right?
Yes,
there is some
yes.
disruption.
Dr. Kwon,
Yeah.
we have to go on with the welcome address and also the congratulatory address. So We will have to stop the transmission within 1 minute, so I will give you 1 minute to finish up your
Okay.
case.
Okay, so you'll see here the struts in the LED. Can you go a little bit downstream? Just a little?
Yes,
Okay.
we can
The
see.
struts are, in the LED are well opposed. This is the DES, the Science Alpine. Shall we go upstream? More?
Yeah,
You
we-
see,
yeah,
you start seeing the BVS struts. There is some disarray, which is quite acceptable.
Yeah. This is
Quite
not unusual
acceptable.
finding from the TAP technique with PVS.
This is very
quite
useful,
stable,
and
yeah.
Usually, this will be covered by thick endothelium, or by time it will disappear.
Okay, so it's time to
Not so
finish the
stressed.
procedure. This is a great case, and this is great to have a case with you, Dr. Santos.
Okay, thank you so
Yeah.
much. It's an
Enjoy
honor.
the
Congratulate.
meeting. Yeah, thank you very much.
Come
Thank you, Dr. Gwon, for your
Good
wonderful case.
job.